Hi there, I'm Dr. Kailey Catapano-Mamone, and I'm here to present you a case of Chylous ascites. Below are my listed co-authors, and we're all from Florida Atlantic University's Charles E. Schmidt College of Medicine Internal Medicine Department. Chylous ascites is a rare phenomenon defined as an accumulation of milky-appearing triglyceride-rich chylous fluid in the peritoneum. Diagnosis typically occurs after a paracentesis revealing milky fluid and elevated triglyceride level beyond 200 milligrams per deciliter. Moving on to our case presentation, we present a 40-year-old female with a past medical history of hypothyroidism who presented with 7 days of constant 10 out of 10 dull abdominal pain and bloating. She also endorsed nausea, vomiting, and night sweats during this period of time. Physical exam was significant for a distended and diffusely tender abdomen, and paracentesis was performed, removing 3.6 liters of Milky Way opaque fluid. Her peritoneal fluid studies were significant for a WBC count of 3,379, as well as a triglyceride level of 2,725. All fluid cultures and gram stains were negative, and of note, her serum CA-125 level was 555, but both AFP and CA-15-3 were both within normal limits. Her cytology showed numerous atypical lymphocytes, and subsequent flow cytometry was consistent with follicular lymphoma. Moving on to imaging, we have figure 1, which is a CT of the abdomen showing a blue arrow pointing to extensive retroperitoneal adenopathy. Above this arrow, just below the ventral surface of the abdominal wall, you can see some mild omental caking, and throughout the entire abdomen you can see ascites. In figure 2, you can see a blue arrow pointing to a 1.5 centimeter enhancing lesion adjacent to the left lower quadrant, as well as the appreciation of that large volume ascites and lymphadenopathy adjacent to the liver. So Chylous ascites can occur due to acquired lymphatic disruption, whether that be secondary to trauma or surgery. It can also occur due to cirrhosis, TB infection, but it is commonly seen due to obstruction of lymphatic flow secondary to malignancy, most often found to be lymphoma. Obstruction of lymphatic flow leads to increased peritoneal lymphatic pressure and leakage of chylous fluid into the peritoneum. CT abdomen is the most useful initial evaluation because it will reveal all of that lymphadenopathy, masses, post-surgical changes, traumatic causes, or the pathognomonic fat fluid level. Lymphangiography is the gold standard for evaluating lymphatic obstruction and leakage, but it's associated with multiple complications, so we typically reserve it for cases of recurrent chylous ascites. Diagnosis, as I said before, occurs after diagnostic paracentesis with peritoneal fluid studies showing the turbid, milky, or cloudy fluid, triglyceride level beyond 200 milligrams per deciliter, cell count greater than 500 with lymphocytic predominance, and a total protein level somewhere between 2.5 and 7 grams per deciliter. The peritoneal fluid should also be sent for albumin, adenosine deaminase, and amylase levels, as well as cytology and culture. In cases where we have clear-cut lymphatic obstruction, like this case, conservative management would be first line and includes a modified diet with high protein, low fat, and medium chain triglyceride supplementation prior to trial of orlistat to decrease absorption of fats or octreotide to decrease the portal pressure and reduce fat absorption. If recurrence continues, embolization, TIPS procedures, or peritoneovenous shunts may be considered prior to surgery. Complications of chylous ascites include loss of nutrients and immunoglobulins, leading to loss of fluids, malnutrition, electrolyte abnormalities, and immune suppression. Also, over time, some patients with chylous ascites may also develop a chylothorax as well. In conclusion, chylloperitoneum is a rare finding that is often associated with concurrent lymphoma. Chylous ascites is diagnosed by paracentesis with milky chylous fluid and elevated triglyceride level. And conservative management includes the dietary modification, but if recurrence continues, may require surgical intervention. Overall, chylous ascites is associated with mortality rates of 40 to 70% and worse for non-surgical cases. Thank you.